Hi, everyone. So I'm going to give it like 2 minutes, 3 minutes for people to trickle in, and then we'll start the panel discussion. Okay, so we're just going to get started due to time. So hi, everyone, and welcome to today's panel discussion, Navigating Home Health for MSA, What You Need to Know About Home Health and Home Care. My name is Lauren, and I'm the Patient Support Service Manager at Mission MSA. We are excited to have you join us for this important conversation about home health and home care for individuals living with MSA. We do have a fantastic panel experts from our Center of Excellence who will share their knowledge and experience on this topic. We will be answering questions at the end of the panel. Before we dive into the discussion, I would like to give each of our panelists a chance to introduce themselves, their role, and their clinic. So I will start off with Lauren.
Hi, I'm Lauren Zaloof. I'm a clinical social worker at the Parkinson's Disease and Movement Disorder Center at the University of Pennsylvania, so Penn Medicine, in Philadelphia, where I've been for the last 4 years. So essentially, I see my role as supporting patients and their care partners throughout their journey with their movement disorder. I essentially help in 4 areas. So providing emotionally supportive counseling, education, help with long-term planning, and then resource connection. I facilitate support groups, so one of them being a group for people with an atypical Parkinsonism, including MSA and their care partners, which is a virtual group. I also participate in our COPE clinic, which is for people with an atypical Parkinsonism. It's a once-a-month multidisciplinary clinic, which I'm the social worker for. And then I also help coordinate our care partner series. So it's a virtual speaker series and support groups for care partners. So all of that, a lot, but all to support our families and patients.
Thank you. And then now it will be Erin.
My name is Erin Taylor. I'm a social worker from Mayo Clinic in Rochester, Minnesota. I have been a medical social worker for 20 years. I've been with palliative medicine for the past 6 years in the outpatient clinic, specifically working with the MSA clinic, which is our palliative providers are embedded within neurology. And so they see many of the MSA patients that come to Mayo, and then referrals come to me for coping and support, for caregiver support. And then I too run a program called Meaning-Centered Psychotherapy. And so we see a lot of patients with MSA who are struggling with meaning and purpose and provide support kind of around that virtually. And we'll be starting one for caregivers here in the fall as well. So happy to be here.
Thank you. And then next, Sheila.
Good morning, I'm Sheila Storch and I'm with UT Southwestern in Dallas. I have been with UT for 2 years after leaving the private sector and now in a teaching hospital. I have been doing social work specifically in neurology for 33 years, and Currently am responsible for the MSA Clinic Center of Excellence at UT Southwestern. And that entails our clinics that are multidisciplinary clinics that involve palliative care. We have a rehab physician. We have typically he will evaluate for needed medical equipment. We have a nutritionist, a social worker, and then research as well. So typically they'll be evaluated for clinical studies. During that clinic, everyone is evaluated by all the providers to see what the needs are from a month-to-month standpoint. So basically, we get to see them from the time they're diagnosed all the way through the palliative stages. And I also am excited about this 5K MSA for a Cure coming up in Dallas. We're coordinating that as well. Dr. Vernino is the one that heads up our clinic. He's actively involved in multiple studies, hopefully for a cure.
Thank you guys for sharing and giving us a brief description of your role. So now we're going to get started on some talking points. So I will start off with Lauren. The questions are going to be geared towards more role of home health care. Can you explain what home health care is and how is it different from other types of in-home care?
Sure. So I like to explain home health care. I like to hone in on the health. So it is considered skilled, clinical, medical services. So compared with home care, it's more about custodial care or non-medical care. So thinking about help with your activities of daily living. So when we think about home health care, those are medically necessary services. They're ordered by your doctor or your healthcare provider. It's covered by insurance. It does require a homebound status, which I'm sure we'll get into a little bit more, but essentially it's a taxing effort for you to leave your home. So whether, that doesn't include going to your doctor's appointments or religious services, but getting out of the house is very difficult. It's short-term and it's goals oriented. So that's home health care. Home care there's more involved in terms of the aid can help with a lot more things. So one thing, I don't want to get ahead of myself, but in terms of services that include under home health care, and I'm in PA, New Jersey, Delaware, that's our area. So I'll speak to kind of my knowledge on that. But in this area, home health care will include skilled nursing, physical, occupational, and speech therapy, a medical social worker, and then there's also an aid piece to that. Under home health care, the aid cannot stand alone. So your doctor can't write an order for an aid. The aid has to be coupled with other services. So the aid has to come with the skilled nurse or with the physical therapist. And the aid is very limited under home health. So they can only help with skilled personal care needs, like giving you a shower or helping you with shaving, helping you get dressed, helping with toileting, like other hygiene related tasks. But there maybe can come out at most for like 2 to 3 times a week for an hour to give you a shower. So it's very limited under home health because, again, it has to be skilled. There has to be a real medical need, like required by a licensed provider. Under home care, the aid can do a lot more things, right? They can not only help with personal care needs, but they can also help with other activities of daily living. So like feeding assist, help with walking you to the bathroom, help with getting you in and out of a chair. So for transfers and other instrumental activities of daily living, which is just a fancy term for saying additional things like, grocery shopping, helping with meal prep, helping with light housekeeping, whether it's running a vacuum or taking out your trash and laundry. The other thing they can do is remind you to take your medication. The aid can't administer the medication, but can remind you like, hey, it's time to take your 9 a.m. dose. And they can also be there to do an activity with you. Maybe, you're struggling to get your exercise in, and maybe they're going to do some exercise with you or provide companionship. So the aid under home care can do a lot more than an aid under home health care, which again has to be coupled with other skilled services. I know that was a lot, but that's the way that I kind of put them in two different buckets.
Thank you. So, Erin, this question is going to go to you. I know that Lauren touched a little bit about the eligibility, but can you give like more details in regards about how does the referral process for home health care work and who can initiate it?
Yes. So kind of like Lauren said, with the skilled piece of home health care, it has to be initiated by a doctor. So there has to be a doctor's order written, and a face-to-face visit has to have happened in the last 30 days in order for insurance to cover that. So oftentimes in our clinic, we will write orders for home health care, but sometimes we will defer it to the patient's primary care doctor, who often sees them a little more frequently and can continue to write orders if needed. They do have to be, patients have to be homebound. So like Lauren said, it has to be a taxing effort for them to leave their house. So doctor's appointments or religious services are about the only two things that patients are allowed to go to while they're receiving home health care under that skilled benefit. So again, an order from a physician, social workers can certainly help initiate that order or organize and get that referral sent with the order with the face-to-face documentation provided.
Okay, thank you, Erin. So this next question will be going to Sheila. I know that Lauren talked a little bit about the services provided, but can you talk a little bit more about like how the care plans are customized to each patient?
Yes, and I have to say, in listening to both Lauren and Erin, it's interesting. Everything is spot on, but there are definitely differences depending on the area. For instance, we are seeing a lot more Medicare Advantage plans than we are traditional Medicare, and that is a huge difference. So when you're talking about coordinating care and patient choice, some of that is limited. It is limited under the Advantage plans as to what home health care agencies take what plans. So where Lauren was talking about a medical social worker and a home health aide, those used to be readily available, but with some of the Advantage plans, neither of those services are longer available in the Dallas Metroplex area. So typically they will be the skilled needs. They'll be the speech, occupational, physical therapy, and nursing. Again, speech and occupational cannot stand alone. So either nursing has to admit or physical therapy. You know, I will say in terms of coordination of care, we do our very, very best to give patients as much choice as possible, but those choices are often limited based on their care plan. And we're seeing that more and more with open enrollment, probably in the last 3 to 4 years. Now, traditional Medicare is much easier to coordinate and to give patients their preference, and to add on the home health aide and sometimes a social worker, but not always. So I just want to make that clear. In terms of care coordination, we work with physical therapists and occupational therapist and speech therapist all the time. Their input is critical. And again, it has to be a taxing effort for them to leave the home. So they're going into the home and they're able to provide us with information that we would normally not have in terms of what the home setup is like, concerns about care, caregiver fatigue, caregiver burnout, falls. So open enrollment's an important time for our patients to choose wisely and to have the knowledge about the different plans, particularly when it comes, and again, I don't know, I can't speak for the other areas, but particularly the Medicare Advantage plans that offer the HMO plans that are highly restrictive. And by restrictive, I mean they may only give 2 or 3 visits, and then we have to submit the need for additional approval on visits, whereas Medicare is much more generous and easier to work with in terms of the number of visits.
Thank you. So the next question is going to go towards Lauren. This is more about the benefits of home health care. Like, what are the main benefits of receiving care at home compared to like a hospital or like a nursing facility, skilled nursing facility?
Yeah, so just probably the most obvious is being in the comfort of your home, right? It's you have access to hopefully your caregivers or the people that take care of you and your support system. So I think, if you're struggling with maybe your care partner is struggling with transferring you in and out of bed, or you have trouble in the bathroom, in the shower, they can go to your home environment. The physical therapist can work on bed mobility in your bed. The occupational therapist can go into your bathroom and see what you're having trouble with. So it's having access, I think, is very helpful. But then also, let's say your care partner wants to learn what you're learning in physical therapy, and them being a part of those sessions hopefully are a little bit easier. Another benefit is you don't have to worry about transportation costs getting to an outpatient physical or occupational therapy appointment. And maybe that's better for you if it's safer because of a falls risk. So it might just be, actually just easier that way. But I think just having access to your home environment rather than having to recreate it in an outpatient setting is a great benefit.
Thank you. So next question is going to go toward Erin. I know Sheila talked a little bit about Medicare Advantage, but could you like kind of outline the different payment options for home health care?
Sure. So for skilled home health care, which is kind of what we've been talking about, this is billed under insurance. And so insurance does dictate sometimes aspects of the care that you're receiving at home. So it could be dictated with an agency, only this agency is a network. If you have commercial insurance, often there's in-network insurance companies versus in-network home health care agencies versus out of network. And so often calling your insurance company to say, can you send me a list of in-network providers, can be really helpful when patients are deciding who's best for them. There's also long-term care insurance, which can cover aspects of home health care, both custodial, kind of those things that Lauren talked a little bit about with housekeeping sorts of things, or a home health aide. Sometimes under long-term care insurance, those services are covered under long-term care insurance. And then there's also state Medicaid. And again, this could vary by area. Certainly in Minnesota, that can be dictated by how much care the county has assessed you to be able to receive, and what kind of services can be provided in your home. And often that is through an assessment by the county, which social work can certainly help initiate. I'm trying to think of other insurance. VA insurance also, if somebody is a veteran, sometimes there's a little more benefit available to patients and caregivers for home health care. And so that's certainly something people should check into if they are a veteran and are service connected. Anything I'm missing, Lauren or Sheila? Thank you.
Okay, thank you so much. Sheila, so my question to be for you is going to be more like in resources and support questions. So what are resources available to help families find and select the right home healthcare services?
Well, depending on the insurance plan, again, if it's a Medicare Advantage plan and you have a catastrophic illness, something like MSA or a movement disorder, or neurodegenerative diagnosis, I really encourage our patients to get in contact with their insurance company and ask for a case manager that can help advocate for you. That's not always available. However, when it is available and we have a contact name and phone number, that's tremendously helpful in terms of, number one, receiving support. Some of the Advantage plans may even provide transportation to and from doctor's appointments, but not always. It again depends on the plan. And if it's an HMO, again, it will be much more restrictive. And then the other component to that is getting in contact with your insurance company, which Erin touched base on, to see which home health companies are in network in the immediate area. What we have found, though, is a lot of the insurance companies will provide agencies that are no longer in business, aren't in the area anymore, no longer staff that particular area. Because home health is such an evolving arena, keeping an updated list can be difficult, and the insurance companies aren't great at keeping up with your own list. So it really is imperative to have a social worker on board to help navigate what's the best company, depending on the area, the needs, and providing the patient as many choices as possible, given where they live, their level of care, the Advantage plan that they're on, or if they're traditional Medicare.
Thank you. And then this question is still geared towards you. Are there like any like Medicare tools where you can like family members or patients can go and look at the ratings and stuff like that?
They do. You can look at the Medicare website. One of the things, and I would love to hear from Erin and Lauren both on this. One of the things that I find the most difficult is I feel like the Medicare website can be difficult for our patients to navigate, number one. And number two, I feel like there is interpretation in terms of how the guidelines are written. For instance, I've had patients who have been on home health for 6 months and then they're ready to discharge. And my patient will say, I have a neurodegenerative condition. I see under Medicare that I can be under home health under a maintenance mode. And while that may be written in black and white, you will be very hard pressed to find an agency that's going to keep you on staff long term if you're not making consistent progress. And as we all know, in our, with our patient population, there are many patients who are progressive. They're not going to necessarily make marked improvements in therapy. And that's where it becomes a bone of contention in between what Medicare has written and what is reality in terms of what home health provides. So bridging that gap and using other services that Erin talked about, if you're VA or you're veteran connected, if you have long-term care, that's a whole different arena that could be another entire presentation as to how to access long-term care if you have a policy, and how to get the documentation needed. But that's definitely a component that could be helpful in setting up in-home attendants or caregivers on a long-term basis.
Yeah, I get questions like that all the time, like, but Medicare says this, but it doesn't actually happen in practice, for example, because the tricky thing with home health care is the goal is to help either regain or strengthen skills, and they want to see progress. And once you plateau and stop making progress, you're discharged. But yes, I hear from my patients, well, I'm going to need maintenance or, therapy to help kind of keep the skills that I have so I don't lose them. So as long as possible, which is, I think, easier in outpatient therapy to support the need for continued therapy with different codes. And our Parkinson's therapists for Parkinsonism therapists have figured out a way to kind of add in certain codes, but still Medicare won't pay forever, right? And I think with home health care, it's really hard to prove. Sometimes I have patients who get discharged and then let's say they have another fall or, there's a new need, like maybe they're on a new medication or there's some kind of change, functional status change, like they're now requiring help with getting in and out of the chair, or they need more help to get to the bathroom. So there's some kind of change that needs to happen for them to then be skilled again to get back on services. So unfortunately that leads to gaps, one home healthcare episode, then a couple months off, then, start again. So it's just, our healthcare system isn't set up to kind of support these progressive conditions that need ongoing therapy.
Well, and under what Lauren just said, I want to add, not only will they be prepared to discharge, they will be prepared to teach the caregiver how to do their routine so that they can discharge. That is the teaching role is a big part of this, so that they can limit how long they're allowed out under the plan. So really and truly, the plan dictates how long you can stay in, and the documentation is necessary to continue.
Thank you. So this question is for Lauren. I know you talked about, Sheila talked about the teaching role, about the providers teaching care partners and patients on like steps to do for taking their medications, physical therapy, but how can patients and their care partners stay informed and involved in the care process of home health care with their provider?
Yeah, I mean, I think, again, if you can't be present because thinking about care partners that work or can't be in the home, I think being, available by phone or FaceTime or kind of setting up a time for a care conference, but kind of making sure you're in touch with the different providers that are coming into the home. And even if it can't be the main primary care partner, can it be a family member or a neighbor, someone else who can be there just so that the information that's being taught to the person is witnessed by someone else, just because, like Sheila said, so that information is being carried over. And it's also like for safety reasons. If we're trying to prevent as many falls as possible, how can we make sure that the care partner's in the know about what they're teaching, what they're learning? So I think being present, but also being available by phone so that if care providers do call to provide updates, that a care partner can hear that information. I would also say that our, like through Penn Medicine, we have our own home healthcare team. So we collaborate, they're constantly writing messages to us, kind of trying to collaborate about a patient. So that would be, I think, really huge, is not just the care partners being involved in the care, but making sure that the information that the home healthcare team is working on with you is brought back to your provider. So we're all kind of on the same page.
Thank you. So this question is going to go towards Erin. So this is more, we're switching over to private caregivers now, not home health. So for Erin, what steps should families take to research and find a reputable private caregiver? You're muted.
Sorry. It's a great question that I get frequently about finding a reputable private caregiver. I think lots of different ways to find a private caregiver. Certainly word of mouth is huge, knowing, talking to other people in the community, whether it's at church, whether it's at your, friend socialization types of groups, knowing what other people have used. There's definitely some websites that you can access, which I think there's another question in the future that we'll talk a little bit more about. But contacting the home health care agencies themselves that are licensed often have kind of a branch of their home care agency that does, you can hire their home health aide to do private pay caregiving. There's also different organizations, even nationally. Home Instead, Visiting Angels are some of the ones that we use a lot in our local area that I know are national companies that's all they do is private pay caregiving. So I think those are some ways. I think for some families, they have contacted local colleges or their universities, hiring nursing students who want, extra work and have some training can also be helpful in accessing care. Yeah, those are the ones. I don't know, Lauren or Sheila, if you have other ideas for accessing private pay caregivers.
Another idea is, like in your faith-based community, if you're involved in one. So I often have people say, look for a retired nurse at your church, for example. Just if you feel more comfortable going that route, or like if you're living in a 55 plus community and you have a clubhouse and there's like a bulletin, kind of putting something there, or it's all word of mouth. But another one is I have, maybe your adult children are on Facebook and there's a Facebook community page and you can post like, we're looking for a caregiver with these kind of requirements. So I see it on there as, when I'm on Facebook. So, there's just different ways of getting the word out.
Well, and to that effect, I also, because so many of our patients from UT Southwestern are coming from outlying areas, small towns, out of state. You know, we don't always have access to who are the best private caregivers in Dallas. Now, when you've been doing this for a long time, you do get some agencies that kind of stand out. And the way I kind of make a very careful list so that everybody gets a chance to be represented is I ask my patients, how did it go? How did it go with this agency? What were the good things? What are the things you would change? And what ends up happening is you'll get some really good feedback, which helps you kind of help our patients navigate. And then I also look at Google reviews. I look at the agency with the most Google reviews and the highest ratings, and then I read them. And you can get some really consistent feedback. And you can also see where some are, some of the reviews, are just, an opinion, but sometimes you can follow a consistency that is helpful in choosing if you're going to go an agency route as opposed to an individual. I don't know. Do you guys have care.com? Do Aaron and Lauren? Yeah.
Yeah, I do give out care.com and also CareLinks, which is another kind of website that you can, it helps with hiring independent caregivers.
Yes. So this question, because all three of you guys answered it, so if someone wants to answer, like, are there any like specific websites or organizations that provide reliable information? So like such as like the Caregiver Action Network, they offer like information, but is there like another organization that patients can use?
Care.com actually has, if you're going to go the care.com route, it's nice because you can pick your own caregiver, and really and truly, I just encourage my care partners to go with your gut intuition, because it is usually going to be spot on. You should know, like within the first couple of minutes, yes, this is someone that could work with my loved one and seems to have the same temperament and has a good vibe and is going to be positive and be proactive, or this is not going to be a good match. And then care.com, they allow you to choose whether or not you're going to take out the taxes, and they give you the opportunity to do a background check. So, and then I call the references for sure. Make them provide references and call them, do the due diligence, because, I just can't stress enough. Someone's in your home and it's important to do the due diligence. And again, like Aaron and Lauren both said, word of mouth is great. If you've had a caregiver that's done a terrific job with someone else's loved one, and you're able to get them to move over and take on the responsibility for your loved one, that's the best. But that's not always readily available for a lot of our folks that have limited contact with caregivers.
I think, it's important to add that sometimes, it is trial and error to find the right person. It might feel like shopping around. And I know that's the part of the process that feels very frustrating, because you want it to be a good fit on the first try, but it might have to, take a little time to see if it's a good fit, because you don't, yes, you could, figure it out on your intuition or on the first time meeting them, but it's hard to really get a sense until they're working with your person, right? So it might just take a little time, and that's normal.
Okay, so this question is going to go to Sheila, and this is more like the interview process. I know you talked a little bit about care.com, but like, what are the most important questions for patients or care partners to ask during an interview for a potential private caregiver?
I always ask about their history in terms of who have you taken care of previously? What was their level of care like? How did you get into the caregiving business? And especially if they're independent, I definitely want references for sure. And then there are some caregivers who are not as good as providing heavy level of care and heavy lifting as other caregivers who are much better at navigating the socialization piece and taking them out to the grocery store and running errands. And some caregivers, I mean, can be exceptional to the point where they take their patient to the doctor's office, and then, you know, the spouse or the caregiver or the family member who's working FaceTimes during the appointment. So that way they get the best of both worlds. They get the logistic of not necessarily having to leave work, but staying informed with the medical physician and having the caregiver provide the transportation and the support. So I can honestly say, in terms of, I had to hire 4 caregivers for my father. So in that process, I can tell you, I learned a lot about hiring caregivers. And Lauren was correct. Some are better than others. But what I did find is I really was able to tell whether or not, because half of it is having your patient be ready to accept the help. I've had patients that say, I do not want a babysitter and I don't want someone just staring at me all day. So one of the things that I think is helpful is to make a list of expectations when you're interviewing. These are the expectations. This is what we're looking for. And I know this is going to come up at some point, is what is the minimum and what is the cost and all of that. But a lot of these agencies and a lot of caregivers have a minimum of 4 to 6 hours. And I've had patients say, I don't have 4 or 6 hours worth of work. I'm like, yes, you do. I can promise you. If you're going to let them do your laundry, change your linens, pick up your medications, go to the grocery store, do all the meal prep, you know, logistically, it's a day-to-day task. Empty the dishwasher, take out the trash, help you with anything else that you need help with. You can get into a routine where you can maximize that caregiver.
Thank you. This question is for you, Lauren. I know Sheila talked a little bit about background checks and references, but for those who are doing like the private route and hiring independently, how should families conduct background checks on private caregivers?
Well, just going along with the care.com, I know they do the background checks for the caregiver, so that's good. I believe families can pay out of pocket for their own background checks. And Erin and Sheila, please add in if you, I don't know if you can ask your local police department, or I'm less familiar with this.
I think you can ask like private investigators to do background checks for you. Sometimes you do need a written consent from the person that you're
Okay.
doing a background check on, because they need to give their personal information that that's okay. But I do know there are private investigators that will do background checks.
Okay.
And then the beauty of using like a home care agency is they can do that for you. Sorry, go ahead, Lauren.
No, it's okay. So this question is geared towards Erin. What is the typical cost range for hiring a private caregiver, like hourly, per hour?
So I imagine this is gonna vary by where you live. So the cost in Minnesota probably is gonna vary from Pennsylvania and Texas, I imagine. Often the agencies here have a minimum amount of hours, like we talked a little bit about. So in order for them to hire a caregiver, they need to be able to promise them a certain amount of hours and a wage. So what I've seen here is, I would say, anywhere from probably $20 to $60 an hour, depending. There's also an assessment fee that some agencies charge because they're having a skilled nurse come in and do an assessment, a needs assessment. And often that can range anywhere from $100 to $250 for that assessment to happen, which is all private pay. And then again, the cost per hour can vary. I don't know if Lauren and Sheila have any other experience from amounts of private pay caregiving.
Well, there's no, it's definitely expensive.
Yeah.
The one other thing I would mention is that usually what I've seen is if you just need someone to provide companionship, so and more kind of the tasks around the light housekeeping or meal prep, that kind of thing. It's less expensive for companionship than personal care needs, at least in Pennsylvania. So maybe the rate is a little bit lower when it comes to companionship. I don't know if you guys have seen
Yeah,
that.
no, I totally
Okay.
agree with Lauren on that. So the rates vary, but typically we start around $30 an hour, and then it can go up depending on if you are non-ambulatory and you need help with continence care and turning and lifting, that is most certainly going to be a higher rate per hour than someone that needs socialization, help with errands, help with getting to doctor's appointments, and that sort of thing. And we also have a 4 to 6 hour minimum. 4 would be difficult to find, but there are some. Typically, it's at least 6 hours. And then some have, 26 hours per week. So it can vary tremendously depending on what agency you utilize.
Yeah, in this area, it's usually 4-hour minimum and 20-hour a week. When people say, even though I agree with you, Sheila, it does add up with what you need help with. If I hear people that say, like, I really don't need that right now, or I'd rather start small and then increase, it might be worth looking into an independent, like individual caregiver who might have more flexible hours or, and can make your schedule work.
Okay, thank you. So this question is going to go towards Aaron. Are there any financial assistance programs or insurance options that can help cover the cost of private caregivers? Because I know Medicare and private insurance covers like home health, but are there any services for specifically hiring a private caregiver?
Yeah, so definitely when you're on state medical insurance, there are some home care agencies that act kind of like a broker. So if you are assessed by the county and they say the county says you qualify for 6 hours of home health care a day for custodial type care, grocery shopping, laundry, housekeeping, meal prep, they can contract with a local agency. And then that agency can hire sometimes even family members to be able to provide home health aides or PCA type care. And then they act as, again, the broker to be able to pay somebody. And that then is all funded through the county. There's also a grant available, and I don't know if this is the time to share this, but there's a caregiver grant through the PSP organization. And if you have an MSA diagnosis, you can qualify for some home care. And then I also have the VA on my list as well. Anything else, Sheila or Lauren, that I'm forgetting?
And you might get to this, but usually I also say that if you have any questions about what you might qualify for, if you do qualify for the Medicaid waiver, which is what Erin was referring to, the first place you could either talk to a social worker or reaching out to your county area agency on aging. There's one in every county in the country under the Older Americans Act, and that would be like your great kind of source of information to find out kind of how to start the process to apply for services.
I totally 100% with that. And the VA is actually really, really helpful if you're service connected. So I always ask, they have provided a tremendous amount of care in the home as well as long-term care benefits. So it's always worth asking.
Okay. And this question is for Sheila, still in regards about income-based eligibility. Are there like any income requirements or thresholds for patients that they must meet to qualify for home health aid under like Medicaid if they're trying to get Medicaid? Is it like a threshold?
Yes, with Medicaid, and I think Lauren touched base on this earlier, you have to meet on 2 levels. You have to meet on the need for care, and then also in the level of care as well as financial. So, and typically it's based on monthly income and assets. So, and that can include you know, having a take in 8 siblings and having farmland. That can be a problem in terms of accessing care. So, or having, usually the home does not count, and either does a vehicle, one mode of vehicle. They also look at, if you've got a spouse working, they're going to look at household income. So, but Texas is pretty strict with Medicaid. It is definitely, when I moved to Texas, I noticed the income criteria was significantly harder to qualify for than where I came from up north. So Lauren and Aaron may have much more generous guidelines for Medicaid than we do in Texas. So, like for the community attendant program under Medicaid, the income criteria I want to say is 2,000 monthly, and then the assets savings is 3,000 total. So
Yeah, so this question is tricky because it is so state dependent. In Pennsylvania, it's based on, so if you're a married couple, it's based on only the applicant applying for the income criteria. So you can't have more than 28.29 a month, and you can't, but if it's a married couple, it's based on their joint assets. For an individual, they can't have more than 8,000 in savings and assets. So it's a lot higher for a married couple, but all of that has to be processed by the county assistance office to kind of check out what are the assets and what can you retain and so forth. So it gets pretty complicated.
Yeah, I encourage people to call their local county and ask for an asset assessment, and a social worker, here at least, a social worker and a public health nurse will meet with you and kind of talk through what your needs are and what your assets look like, and then work on kind of planning for the future as you start spending down assets. It's important to kind of know what those thresholds are based on where you live.
Thank you. I know everything's like more complicated when you get in regards to like Medicaid because it's state and federal funded. So each state is different. So I highly suggest if people are looking in regards to Medicaid assets and seeing about having a private caregiver, like everyone says, the county, local department of aging, they'll be able to assist you. So this will be our last question. Everybody can answer. This is more in regards about supervision and evaluation. So how can families effectively supervise and evaluate the performance of a private caregiver?
well, this is a really hot topic, actually. And part of that is the invention of Ring doorbells and cameras inside, and there are caregivers that don't want to be watched. But it is absolutely the right of the homeowner to be able to do that, especially if you have somebody in the home and you're not in the home and you've got somebody that's dependent on care. So that is definitely one. And then others are just being very conscientious to put up valuables, checkbooks, that kind of thing, so that you're just avoiding any potential issues. And then the other thing is I'm sure Aaron and Lauren both, we have patients that are on sensitive medications. Some of them are pain relievers, taking an inventory of medications, looking at the medications, whether or not while caregivers in our area cannot physically dispense medication to a patient, they can provide reminders and say it's time to take your medications and watch them take it. So if medications are being missed, that's significant. If our patients aren't being fed and are not getting lunch, they're just kind of getting a brunch, that's kind of a red flag. Those are just a couple of things that come to mind. Coming late and leaving early, that's the other. I don't know about Aaron and Lauren, if you guys have any others.
I just had, looking for obvious signs of neglect, or not good care. Somebody's supposed to be getting a shower and you get home and obviously they don't seem as clean as what they should seem. Definitely those obvious signs. Lauren and I talked a little bit before we started about this question because it is a hard question. But I think certainly listening to the patient, you know, if they're uncomfortable, if they feel fearful, watching for body language, you know, tension, and getting their feedback and input. Certainly you want there to be a good relationship between the caregiver and the patient.
And then, you know, maybe initially, if you don't feel comfortable leaving while they're there, maybe it's staying in the beginning. And I understand that a lot of people bring in care for respite. So we, of course, want our care partners to get that time for themselves or to be able to get out of the house. But in the beginning, maybe you don't feel comfortable yet. So, you know, it could be that you're there while, you know, the caregiver is there. Maybe you're on a different floor or in a different room. And then once you do feel more comfortable, you know, then leaving. But I think in the beginning, you know, both you and your loved one are adjusting to someone in the home. So I think, you know, if things are different in the beginning, I think that's normal. And it's an adjustment period for everybody.
Thank you. And this is just a follow-up question in regards to like if a patient or a caregiver has like actual like the red flag signs of neglect and abuse, how can a patient or care partner report that information?
If they're working with an agency, it needs to be reported to the agency. But the other thing, and this goes back to a lot is readily available. So if you have somebody in that says that they're a nurse and you find out something is off or it feels off, do your homework, Google them. And what do you find? Oh, lo and behold, she's not a nurse. She's an LVN. Oh, she got her license taken away because she was taking medications that she shouldn't be taking from patients. That's a true story. And that happens. So do your due diligence. If something feels off, it doesn't hurt to Google the individual provider, and then I definitely would report it to the agency. And if you have significant concerns, and not all of our patients are able to necessarily verbalize that they're fearful of a caregiver or anything like that. But there's always adult protective services if it's a severe case or you have genuine concerns that something is not right. And adult protective services can do the investigation and have a lot more authority in terms of what they can do to investigate a caregiver that you see red flags on.
Okay, so I just want to thank our panelists for such an insightful discussion and their responses. So we do have a few Q&A questions that were submitted, so I'll just ask some of the questions, okay? One of the questions is, how can I, as a living caregiver for an MSA patient, learn how to best take care of his needs, such as pick him up when he falls, best and safety ways to enter the shower?
That would probably, I mean, be a great use of a home health care provider, right? If the physical and occupational therapists are in the home and you want to learn training on the best way to safely shower him, or I think you said transfers. Let me get back to the question. I mean, I think that would be a great source of asking the therapist to show you and to train you. I don't know if anyone has other thoughts.
No, I have to agree with Lauren. That's exactly what we use physical therapy and occupational therapy for specifically. So occupational is activities of daily living, the showering, or getting in and out of the physical therapy is more logistics, the way I think about it: fall prevention, gait training, balance, strengthening, and physical therapists don't like it when I say this, but one of the things I would want if I were a patient is to lay on the ground if I have fallen, is to learn how to get up off the ground if I'm not injured and I need assistance to get up. Because the longer you stay down, you know, we want you up as quickly as possible if you're uninjured. the occupational therapists typically now are doing more of the bathing here in Dallas than they're actually sometimes in lieu of, because we are short on home health aides, and or a lot of times the Advantage plans don't cover it. So now OTs are picking up that part, and that can be really, I like PT, OT if you can tolerate two people coming in and out of your home. Not everybody can, but they can piggyback off of each other to help you with logistics and safe transfers. And for patients who are heavier care, we also use PT for Hoyer lift training if a Hoyer lift is needed for safe transfers, because that can be tricky. That's not just, just order it and drop it off. We typically will order the PT to teach folks how to utilize that safely.
Thank you. And then here's another question. Well, it's a statement, but I can make it as a question. I have had a therapist arrive at my home not being familiar with MSA, which is listed at the top of my diagnosis. So I'm suing the patient's question, like how to educate like a physical therapist or occupational therapist who does not know anything about their diagnosis.
I think that's the one bummer, is that you're hoping that the person that is coming into your home, whether it's a home health care provider or a home care provider, has some knowledge of, healthcare chronic illness or, neurological conditions, but they might not, and they likely don't have any knowledge on MSA. So usually what I tell patients and families is to have literature on MSA so that you can just kind of review kind of a few kind of bullet points of this is what MSA is and this is how it affects me and this is kind of what I need help with, but being able to kind of give that information so that, it's not, the burden is not completely on you. I also tend to offer, like, I'm happy to speak to a provider with written consent and can provide some education. So it does unfortunately have to come from either the person or the family member, or even, as a healthcare team, we can step in.
Thank you. And then this question, there's like two questions. What time of day is most helpful to bring home care workers into the house? Mornings, evenings, which one?
That depends on their schedule. So if for anybody who's done home health, I can promise you, you do not get to pick when you come. So it is basically, if you're talking about home health care and like PTOT, the aid, typically they're going to give you a demographic area to cover, and then you're going to schedule your patients based on where they live and go from house to house to house to house. Typically, and Aaron and Lauren can speak up, but typically they will call the night before, or should call out of courtesy the day before and say, I'm going to be there between 2 and 4. The issue is if you live, across town and somebody is starting at the top, you may get an evening, a 2 to 4 window as opposed to an 8 to 10 window. But a lot of times the therapists don't necessarily get a choice as to, the timing of the visits. The other thing is depending on the patient ahead of you. And if they're seeing 8 patients in a day, if the patient ahead of you is in crisis and something happens and they have to call the ambulance, anything can happen in a visit. So sometimes they're late, or they're running behind, or traffic is an issue. Typically they should call ahead and let you know, hey, I'm running late. I should be there at this time. But setting set times is typically for home health care, not hired caregivers, but home health care is, you're kind of at their mercy as to when they're able to come. So.
All righty, so I think we answered all the questions. We are getting to the hour. So I would just like to thank our wonderful panelists for sharing their expertise and also for the audience for your participations and asking questions. We hope that you found this session very valuable in understanding the various aspects of home health care and for MSA patients. Please remember to complete the feedback survey at the end of the session. Your input will help us improve future events. Thank you all again and have a great day.
Thank you, everyone.
Thank you.
Thank you so much.